Okay, appreciate the opportunity to speak. I'm J.D. Corl, the medical director of the CLI and PAD program at the Christ Hospital in Cincinnati, Ohio, and I work with some of the giants in the field, Dean Kariakis and prior SCAI President Tim Henry. So we got together and wrote a paper on some of the early use of the L6 lithotripsy catheter for some cases back in November. And this case presentation is a spin-off of that paper. The paper was actually published yesterday in JSCAI, so hot off the presses there. Here's my disclosures. So this case is a 65-year-old female with severe lifestyle-limiting claudication, hips, buttocks, legs, both sides, bilateral, equal, progressing over 6 months, and to the point where she had to stop a few times coming into the office for her appointment and rest. So predictable claudication with activity and resolution with rest. Got some risk factors with the coronary disease, hypertension, hyperlipidemia, and the diabetes. So based on her exam and presentation, we were suspicious of inflow disease. We got an aortic iliac duplex study, showed high velocities in distal aorta of about 400 centimeters a second, and below that in the iliacs we saw monophasic flow throughout. So we took it to the cath lab in September, right radial axis, which is my usual approach for the diagnostic images. This showed a 90% severe stenosis in the distal abdominal aorta with a 75% stenosis in the distal left SFA and included ATs bilaterally. So we talked to her about the endovascular approach, risk benefits, et cetera, but also recommended a surgical opinion. So referred her to vascular surgery. In preparation for that procedure, the surgeon requested a CTA, which we got in October. And again, you can see that calcium throughout that abdominal aorta into the iliacs with that severe stenosis, distal abdominal aorta. We also measured that aorta about 12 to 14 millimeters in diameter. Did meet with our vascular surgeon in October, talked about the surgical approach, risk benefits, et cetera. Based on that discussion and discussion we had, she decided to move forward with an endovascular approach. So came back to the cath lab in November. This was perfect timing as the L6 lithotripsy catheter was just released for the limited release, and we were fortunate to have access to that. So again, right radial access, we like to be above these lesions. Any of these distal aorta, iliac lesions like to be above for imaging. And then we got a right common femoral access with an 8 French sheath, cross from below. And again, perfect timing as far as the lithotripsy catheter, but also the size was perfect. We had a 12 by 30 L6 balloon, took it up there, low pressure, 2 to 3 atmospheres, 180 shocks delivered. You can see that lesion yielded nicely with that low pressure. Followed it up with a 11 by 39 Vibon, VBX balloon expandable stent. Post-dilatation throughout with a 14 by 20 balloon. Got nice apposition. And then your final images there. So we were fortunate not only the timing and the technology that was available, but also that this lesion was high enough above the crux that we didn't have to bring the iliacs into play, because that would have been a whole different animal as far as the stent procedure and even the balloons. So just a few words on the technology, some of the features of the L6 IVL catheters. Again, larger size balloons, 8, 9, 10, 12 millimeter diameters. And then, of course, I'll talk a little bit about vessel prep and then the focused treatment with that compact design. And then I'll comment on the energy profile of this balloon versus the M5. So here's your size again, 8, 9, 10, and 12 millimeter diameter balloons are all 30 millimeter length, 110 centimeter shaft, 300 pulses, 018 wire for a little more support. And there's your sheath sizes. Here's how it fits into the Shockwave portfolio. Of course, you have the C2 for coronary, the S4 typically below the knee, M5 plus FemPop segment typically, and then of course the L6 rounds it off at the top with the iliacs with the 8, 9, 10, 12 millimeter diameters. So again, this is perfectly sized for the vast majority of iliacs, and you can see you want that well-opposed contact with your balloon inflation. So these larger balloons can give you that contact, gives you that efficient energy transfer. And again, the key with these heavily calcified large vessel stenosis, you want to keep this at low pressure, because if you have to dial up a balloon To really modify that calcified plaque, you risk the perforation, dissection. So these low pressure inflations are key to lowering a lot of the risk from these procedures. Here's the anatomy of the balloon. You got the 6 emitters, the 3 channels, 300 shocks delivered through those channels. You can see it's compact on that 30 millimeter shaft, so you can get this energy profile here on the right where you get a deep penetration, even energy profile, in contrast to the M5 Plus where you get more spread out. The shocks are distributed differently through the 5 emitters and don't get as deep of a penetration. Of course, the balloons are smaller except for the overlap at the 8 millimeter balloon. So here's that paper that we did just get published yesterday. So this highlights the case we just discussed in a little more detail, goes through the technology a little deeper, and also highlights the first in-world case that we did back on November 7th, where we treated 2 iliacs, common iliacs with, again, 12 by 30 balloon and 11 by 39 Viabons, large iliac vessels in that patient. So here's a QR code if you want to download that paper, available for review. Thank you very much.
Great job. Any questions? This certainly would be great for endoluminal grafts, prepping the vessels, which we've already seen with the IVL, but this gives us a lot more flexibility.